Well, I'm really excited to be here with you all. HIV is really near and dear to my heart. As he said earlier, I was a surveillance supervisor for about 5 years, and our primary goal is to do surveillance of STDs, HIV, and gathering the information that we use to bring in money into our community. So with that, I'm going to just sort of start off with a little bit of an introduction. He gave a kind of an introduction for me, but I'm going to also provide you sort of how I relate to this topic. So is this better? Okay, good. All right. So during COVID, I managed a variety of teams. I managed teams that processed a lot of the incoming labs, the thousands and thousands and thousands of labs. We entered all of that data into a database, and then we assigned investigations to our case investigators. And so that's really the experience that I bring related to COVID. And then I have, as he said earlier, we have Anna here as well. She's worked with public health and about for at least the city for 4 years. She had a wealth of knowledge before that, working in the state of Florida. During COVID, she was like the meat and potatoes over here. She did the planning, the coordinating, and implementing of all the testing sites, all of the vaccine sites, and she made sure that we prioritize equity and access. I mean, I don't know how she did it. It was pretty amazing. All right, so we're gonna just I wanted to kind of just start off about, it's COVID, but we've had many, many pandemics in our history. I mean, starting with this may not even be the first one. The first one we really think of is the bubonic plague. Death toll between 75 and 200 million, lasted about 7 years. It jumped continents. It was transmitted by fleas. We had the Spanish flu, 20 to 50 million. Lasted about 2 years. We had a 10 to 20% mortality rate, and there were up to 25 million deaths within the first 25 weeks alone. We had HIV/AIDS, which is still going on. Death toll in the 36 million. We currently have between 31 and 35 million people living with AIDS. This is not news to this group. Between 2005 and 2012, the annual global deaths from HIV/AIDS dropped from 2.2 million to 1.6 million. So that's some good news. All right, so now we're going to talk a little bit about what we came here to talk about. So COVID, we had 15 million lives were lost just within 1 year with COVID. We closed our national borders. We quarantined for many, many months. It devastated economies, and we're still having impacts in our economies now with just sort of the supply chain and getting things back to where they were before has been really difficult. I'll make sure. The economy loss that is estimated is about $12 trillion by the end of 2020 and 2021, and we're still experiencing it now. And it was more than just the death toll. We had mental health issues. We have physical issues. People just having a hard time acclimating back to what we're going to call our new normal. And it really hit hard in our aging population. I mean, before we all know that before COVID, our nursing homes were very understaffed. Disabled people were neglected. The low-income people were disconnected from healthcare, and COVID just exacerbated all those problems. The chronically underfunded public health system that I work in, we struggled to slow the virus spread until we started receiving some federal funding. More than 80% of the global COVID-19 related deaths were in 2020 through 2021 occurred among people aged 60 years and older. And unfortunately, with us having us quarantine and staying at home and not being able to go into these long-term care facilities because they were afraid that we would introduce something into the community, a lot of these people unfortunately died alone without their close family and friends to be there to comfort them. So I'm going to talk about we're going to talk about kind of what worked well with our response, and then we're going to talk about some of the lessons that we learned that really ties very closely in my world to ethics. They may not sound like they're really close to ethics, but I feel like any disproportionality that is given to care is an ethical issue. So we're going to start with what worked well, because I always like to start with a little bit of a positive. So our leadership, our chain of command, we implemented the ICS structure, which is the incident command system, very early on, really to be able to scale up and down with this response. Communications, well, it has some issues, because communications is always something that you can improve on. I think that we did really well with our internal communications and standing up things and getting us started. We mobilized many divisions within Austin Public Health to address the emergency operations. We brought up vaccines clinics, testing clinics very quickly. We used a lot of the staff within Austin Public Health to do that. Federal funding came in pretty quickly, and we were able to then scale up and hire extra staff to take on some of the areas that were, we just couldn't keep up with the amount of staff that we have within Austin Public Health. We had frequent meetings with our community partners to discuss changes in our protocol, which change seemed like daily. We really reached out to talk with schools, long-term care facility. We talked with restaurant coalitions. If there was a set group of people that we could reach out to really communicate with, we tried to really mobilize and be able to get the information out. It was very difficult to figure out how to get the word out to all the populations that needed to have information given to them. All right. Moving on, we recommended and implemented control measures early, and we're very clear to make sure that we are protecting our community. We've let people know, keeping, covering your cough, washing your hands, social distancing, getting vaccinated when vaccinating was finally available. We were really at the forefront. We tried to keep it simple and keep that message to the people very, very clear and concise. Now, I also have to talk about the dedication and resiliency of our APH staff. We worked really, really hard. We staffed testing and vaccine clinics across the city. We opened a phone bank to capture the public concerns and community needs. We interviewed thousands of citizens. We educated the public and gathered data on thousands and thousands of labs. And we produced dashboards that were used to inform the public, as well as inform our community members, as well as our public health, our elected officials who are then going to go out and making policies. So we did a lot with the staff that we had. Now, there's always room for improvement, and through the pandemic, we definitely saw where things were breaking down. We could have used a more community-led approach. We tried really hard to do that, and I think that, as Anna will allude to later, we're really working on what we're going to do better, and the next time that this comes around, hopefully after I'm retired. Our state directives we're not always in line, or even with the CDC, the federal directives were not always in line with what we were saying. And they changed quite often, so it was really hard to keep up with our message to be consistent with all the parties that were involved. The messaging and messaging services need to be in multiple languages, not just English and Spanish. And we even struggle with making sure that our message is in Spanish, and there's many other languages that our messages need to be given to, because these are the people who aren't accessing care as readily. They're not watching the news and getting the information that they need from the news and that kind of thing. We need to prioritize the underserved and underinsured population. We noticed throughout the pandemic that people who had healthcare were able to get tested. The people who didn't have healthcare, where were they supposed to go? It was really, really hard. It really showed where the health gap between those two populations was really showing and rearing its ugly head. We're trying to make sure that we have equitable access to antivirals and other treatments. So there were other types of treatments available, especially Paxlovid was really very hard to come by sometimes, and if you'd have to have a medical provider to be able to get that a lot of times. And so again, it was one of those things that was really hard to get to the underserved populations. And then I will just say the one that's near and dear to my heart, which is the electronic data management. Public health is there to receive information and how the doctors and the people who are testing want to get the data to us. And what is that? That's the good old fax machine. I don't want to use a fax machine. I just need to make sure I can get the data from people, and that is what they choose to provide to me. So I had thousands and thousands of, I mean, there was a day, like I think it was Omicron when we had that first wave. In one day, we had that much paper that was produced just from positive labs alone. And so really trying to get and look at how we can do things without involving paper and having it be done in a HIPAA compliant and in a HIPAA compliant way so that it's protecting people's personal health information. All right. What could be improved in our community? There are existing inequities identified through the COVID. They continue to persist. The testing, getting access to care. This is going to be like, you know, same thing over and over again. Improving the ventilation in our public indoor spaces. There are a lot of places, including my office, that we ended up putting additional filters in to improve the air quality in our areas so that it reduced the spread of airborne pathogens. Providing people paid sick leave. Not everybody has paid sick leave, especially those that work the front line at a long-term care facility. They want to get paid, so they will show up to work. And when they show up to work, they share a little bit more than just their work and their love. They're sharing the things that they bring if they're sick. And so having paid sick leave and having that be something that is provided to everybody would help that, because they could stay home when they were sick. Access to healthcare. And the last one is community trust. There's just been a lot of, in this world right now, where there's just a lot of sources to get information, and you can, whether it's accurate information or not accurate information, there's just so much of it, and how someone can actually decide what is so and what is correct. It just really erodes the trust we have in the health department. And then also when we maybe don't provide to a certain area of people because we didn't know that we needed to do that, it definitely brings bad press that we have to then learn from, so that the next time we have something like this, that we can address that, because we don't know where our gaps until the gaps present themselves. All right, and then so we're gonna just sort of, like, as I said, ethics I feel like is throughout the whole thing, but I'm gonna just sort of touch specifically on some things that I feel are related to HIPAA and ethics. So I kind of talked a little earlier about there are emerging forms of communication, you know, text messaging. You could do things via, you know, emails. I mean, these aren't really emerging for us, but as far as emerging for the communicating our health information, we tried to really work on getting results to people from their tests via the email, but making sure that they're encrypted. That's not everybody has a technology on their computer or the computer savvy to be able to understand how to deal with an encrypted file. I would send an encrypted file to maybe a hospital saying, I need to have more information about this patient, and they had no way of getting it back to me in an encrypted way, especially the long-term care facilities. They just are not set up to be able to have data go back and forth via email in an encrypted way. And if it's not encrypted, that's where the confidentiality stuff could be, we could have a breach. It's really hard to have a conversation with somebody who may not be technically savvy to let them understand why encryption is important. They may not even understand that that's a violation of HIPAA, because that's not what they had done prior to COVID. They didn't have to report, like long-term care facilities very rarely had to report any illnesses directly to the health department. They weren't testing people, and if they were rapid tests. So they didn't have a mechanism of how to get information. And the Austin Public Health had to create a way for them to do that without them having to go out and buy encryption software in the middle of a pandemic. And then, as I said, as far as ethics, any inequity that's out there really is an ethical concern. There's varied provider engagement. Some providers are willing to do, you know, test and provide vaccine, and some aren't. So because they don't want to keep a vaccine on hand or something along those lines. So even within, if you have a medical home, you may not get the same need, and they have expertises. I mean, what I'm going to kind of sort of touch on this. It's not COVID related, but we had right after I took my new position, we had Mpox. And I found that a lot of providers out there were unwilling to test people for Mpox. And then we would have to drive them, like not physically drive them, but like channel people to the STD and STI providers so that they could actually get tested, because people were not willing to test. So that's what I mean by like provider engagement. Some people are engaged in making sure that they're doing the wide variety of testing that their patients need, and some of them are very narrow. Access to care, again, another, say it every single slide, that has been a huge ethical concern. I mean, I have people even now that don't know where they need to go to get treatment, and how do I get them, how do I get them into care? It's this dilemma that I don't know where to send them to get care, but they need to get care. And they may not have the tools to actually get them to care on their own. I don't know how, we're shortage of social workers to provide that service. There's language barriers. Workplace safety can be varying. One of the things that I want to talk about on the workplace safety is the first people who really as a group had an expression of COVID were our janitorial staff at our long-term care facilities, because they were not being taken care of as far as knowing what they needed to do to protect themselves. They were handling all this stuff that was from people who were sick with whatever they may have been sick with, and they weren't protecting themselves because they weren't told how to protect themselves. So really about making sure that we have consistent workplace safety for all levels, not just the clinical care. And then also just workplace benefits, paid sick leave, paid time off for taking care of a loved one, and that kind of thing. Really is not having health insurance available to all people who have a full-time job or even a part-time job. Like those kinds of things are ethical issues in the world of COVID and just really healthcare in general. All right, I'm going to move it over to Anna now to talk about lessons learned.
Heather. Hello, everybody. I'm Anna Urueta. I'm with Austin Public Health Emergency Preparedness Program Manager. And thank you for having me here today. So a lot of what I'm going to cover actually has been covered by Heather. When we responded to COVID, we obviously had not endured a pandemic of that magnitude or a pandemic before, and so there were a lot of unknowns, but we had a lot of lessons learned. We know that the next pandemic or the next infectious disease outbreak will not be exactly like COVID, but we, especially in the emergency preparedness and response world, we use all of these opportunities, all these experiences to build upon and look at our plans, see what worked, what did we not think of in the past. It's impossible to think of all of the things. So these situations help us with strengthening our plans and really thinking of all of these unknowns and planning better for the future. One of the things we learned during or after the pandemic is that STI rates increased. People were isolating at home, they were not getting tested. And then whenever people started gathering, they started sharing and they still were not getting tested. And so those rates increased. We also learned that there were a lot of issues with access to healthcare, especially during a pandemic when the healthcare infrastructure was already so strained. People were just really having a difficult time with accessing. There were a lot of issues with leave policies, and I know Heather touched on this a bit, but an example something that we saw a lot were, for example, construction workers. They had to continue building buildings and they needed to continue coming to work, and they didn't have the opportunity to stay at home and get paid leave, and so people were showing up to work sick. So there's really one of the big lessons learned there is the need for creating policies that will protect these employees so they do have the ability to get paid whenever these diseases are happening. There were, after COVID, during COVID, we were able to rally and encourage people to get vaccinated. We saw a rise in people getting vaccinated, especially when it was in everybody's face. Everybody knew someone that had gotten sick or potentially that had passed away. People were getting vaccinated. After the vaccination rates increased, people started forgetting about it. We started seeing lower numbers of vaccination rates. So a big lesson learned was, how do we continue to make this relevant, to make sure that people understand it's important to continue getting vaccinated. Shameless plug, get your COVID vaccine. we're seeing a rise in respiratory illness and flu-like symptoms in hospitals and doctors' offices already. So this is a good time as the cold season's happening.
And flu shot.
Your flu shot, yes. So yeah, there's just really the need in public health. We know this, that we're focused on the uninsured populations, but really stepping back and seeing, okay, well, we're telling people go to your provider to get health care, but how are we going to expect that people are going to do this if they don't have a healthcare provider, if they don't have insurance? And so we've really had to sit down and think about that and think, okay, we can't provide this message and say you need to do this without actually helping provide a solution. So it's a lot of policy level solutions that we're having to think about. Oh, I think. Another thing that we really learned too was the need to have plans for isolation and quarantine. We were telling people to stay at home, but there are many families, especially those that are experiencing higher levels of vulnerability. A lot of the times they live in a multi-generational household, a household that has different up to 10 people living in them. And so it's important from our perspective, and it was an ethical concern really, telling people to stay at home and isolate, yet they had really nowhere to isolate at home if they lived with so many other people. And so we've had to really plan that into our emergency plans and make sure that we have a place that we can send people to. And unfortunately, working in government, really working in public sector, in any sector, resources are limited. And so we're battling with ensuring that people are isolating, but also that there are resources that they can turn to so they can safely isolate. So it's a lot of conflicting information that people are getting. I think all of this is covered by you. So are we ready for the next pandemic? What do you guys think? Well, we've definitely learned a lot, and this served as a big exercise. I think one of the biggest lessons learned from my perspective is the importance of having relationships with healthcare providers and making sure that we're communicating consistently and that we're sharing the same message and that we're on the same page about things. It's difficult. For example, with Mpox, we were telling people, go get tested if you're experiencing these symptoms, go to your healthcare provider and get tested. Well, what we saw was that people were going to their healthcare providers and their healthcare providers weren't testing them for Mpox. They would have to go to up to 3 different providers until someone finally tested them, and it turned out that they did have Mpox. And so that link between public health and healthcare providers and making sure that we're educating them as well, so they are testing them the first time around, it will save people a lot of resources and will get them the help that they need more quickly. So that partnership is key. The role of social media, there's constantly disinformation, misinformation. We learned something we didn't have right off the bat with COVID is, as Heather mentioned, we had an incident command system stood up, and we were really focused on operations. How do we get up a testing site? How do we get a vaccination site up and running? But we didn't have, although we had a public information officer, we didn't have a whole section that was really making sure that they were feeding all of the most up-to-date, correct information through the media channels. Up until later on, it took us a little bit to get it together. And so I think that after having experienced COVID, it's really helped us with establishing those structures in place. So now we know that right off the bat, we need to make sure that our public information officers are getting fed information from our epidemiologists and they're communicating so we can push out correct information as quickly as possible. We've created new processes in testing and vaccine management. So I'm not sure if y'all have ever heard of points of dispensing. In public health emergency preparedness, we always practice for worst case scenario, which they've always told us was anthrax. What if bioterrorism occurs and we have an anthrax release? We need to medicate the whole population with antibiotics. We didn't really practice vaccinations. And now that we've gone through COVID, we have robust plans that will allow us to provide vaccines in a mass scale, something that we really weren't very prepared for in the past. workforce is way more engaged in preparedness. I think it was very difficult for me 8 years ago, 10 years ago, to tell people why I thought public health emergency preparedness was important, unless it related to maybe a natural disaster. People just were always thinking, oh, this will never happen to us. I think people now, we have the opportunity to take advantage of that engagement that we've got and make sure that they're thinking about emergency preparedness and continuing to participate in trainings and how to make sure that we're getting the needed medications to the population in an equitable manner. We're going to continue to foster and develop relationships with community partners. I covered the importance of fostering relationships with healthcare providers, but also community partners that serve as a voice for the people that they're representing. It's very important to leverage those resources and make sure that we're not just the one voice that's pushing out the information, but that we're able to communicate in all of the ways that we can possibly do so. And I think that's all I've got. Really continue to methods to engage community. So really, I mean, as far as the ethical perspective of all of this, big lesson learned for us is just how to really think about all of this from an equitable perspective, not just how do we get vaccinations to the mass population, but how are we really going to reach those people that aren't able to get it to a vaccine site, that don't look at the regular news channels. So lots of lessons learned for sure. I think that was it.
Y'all have any questions? Yeah.
I'm going to come to you with the mic.
The question I have, actually, lots of questions, but I'll leave it to the two, is why are we not communicating more in the public about getting boosted for COVID? Because right now, even healthcare entities, when you go to work for them, hospitals, will say, as long as you got the first two, you're good, but you still need to get your flu, but you don't need a booster. So why aren't we communicating more about the necessity for the booster?
I'm actually going to take a stab at this, but I mean, I don't really know the answer to this question, but what I will say is that I think that there wasn't a lot of information from the people who are producing the vaccine as to when it was going to be available. It was all of a sudden like, oh, it was available. We do some advertising for our shots for tots, our big shots and that kind of thing. But we really have, in the past for flu, we really relied on our partners like Walgreens and the community to provide it to the masses. So I would agree that we haven't done a very good job of making sure that people are aware of the boosters and how important they are. Do you have anything to add to that?
It's still needed.
Yeah.
It is.
Yeah, if I may, also, and I'm not by no means an immunization expert, but I do know that there has been a shift from the pandemic where we were getting funds directly from the state and from the federal government for providing the vaccine. And the state was encouraging us and allowing us to advertise COVID vaccines. Unfortunately, there are certain laws that have changed that prevent us from openly advertising or pushing vaccines as much as we were in the past. So there's some, and Heather had mentioned one of the issues that we encountered was the state and local government sometimes not seeing eye to eye or communicating. That's an ongoing situation. And I think that does contribute to the lack of information.
I forgot about that. Yeah, we can't just offer COVID if it's tied to state funds, which a lot of our stuff from the city are from state funds.
I know that for my husband, he's on SSDI and he's on Medicaid. So we had set up that we were going to go get our COVID shots at the pharmacy. We get there and the pharmacy says, oh, we can't put through Medicaid. You're going to have to go to your GP. They are the only ones who can give you a COVID booster and have it go through on Medicaid. So people who are on Medicaid are very limited on where they can go and get their booster. Kind of related to these types of things, you had talked about access to the message, you know, in during a pandemic. What are some of the plans that are going into place? You know, we're serving older adults, many of whom are not tech savvy, who don't know how to get this information, how to sign up for the alerts. We know that during COVID that around 90% of all older adults got no medical care at all because they had no idea how to use telemedicine. And even if it was available, we look at areas like in East Austin, in East Travis County, like Harmsby Bend area, where 95% of the population is older adults, yet they have very limited access to care. What are some of the thoughts and plans for being able to, in the next ice storm, in the next pandemic, we know something's going to come next. How are we going to be able to reach this population and be able to effectively get them to the resources that they need?
So I will say that unfortunately, the way that we're approaching this is that as far as is a disaster coming, we just are going to assume that we're going to have a winter storm this winter. It's the climate's changing, and so we're just expecting and we're just planning for the worst. I think that there's still a heavy reliance on electronic type of like virtual visits and text type things, but there has been an improvement and an increase of outreach events. So from the emergency preparedness side, we've been having monthly outreach events where we're out in different areas of the community at libraries and tabling events where we're sharing information and helping people sign up for Warren Central Texas, the text messages that you receive to get more timely messaging. But I think that there's still an opportunity there to continue to partner with providers and with organizations that are communicating directly with the folks that we want to serve and ensure that we're all sharing that same message. So there is an increase in outreach events and being out in the community, but there needs to be more, and there needs to be more partnership building. I think we really need to rely more on those partners.
Well, you're preaching to the choir, and the choir is right here. So, these are the providers who are serving that community. So how can we better help the city and the county to be able to get that message out? Because we're the ones who are the first line to these folks. What do we need to be telling them? What do they need to do? What are some of the things they need to sign up for so that they are prepared? Because as you mentioned, preparation is going to be what's most effective.
Yes, thank you. Definitely help people sign up for Warren Central Texas. I'm not sure if everyone here has already signed up for Warren Central Texas, but it's actually really simple process to sign up online. And then afterward, you can come up and I can make sure that you're signed up. You can communicate that with the folks that you serve. That will allow people to get a text message or a phone call directly on their phone, and it will tell them, hey, we see that a winter storm's coming. You need to do these steps to make sure that you're prepared. Another resource is STEER. It's a registry that is managed by the state. It's not a perfect registry. Registries are really difficult to manage because it's really something that every single year you should go in and make sure you have updated information. But STEER, and we should have shared the information. I can happy to though. STEAR. That's you can go in there and provide where you live, what kind of medical vulnerabilities you have, and we use this information at the Emergency Operations Center whenever there is a disaster to see what areas of where people are and where the people that need to be prioritized live, so we can go check on them. And then finally, there is Austin Energy. If it's an Austin Energy customer, they have a medical vulnerable registry, and that one's a little bit trickier to access. You have to have I think you have to have your healthcare provider provide some information, but the individual can go on there and register. And if they're able to get in there, which you can call 311 to get help with registering on that, or go on the Austin Energy website. Whenever an emergency happens, the Austin Energy can see what area has been affected, and they will call people that live in those areas to make sure that they're okay. And they help with preparations.
Yeah, thank you for mentioning STEER, because that is a great program that in a perfect world during an emergency situation that they will send out the emergency teams to go knock on the doors and say, are you okay? What do you need? Oh, you don't have electricity. And your dad's on oxygen. We need to do something about that.
Yes.
So that's a great one. And I know that care partners can actually go in and sign their care recipient up. So the recipient themselves do not have to be the one signing up. The care partner can do it for them. So that's a great one. You had another question.
Oh, yeah. The other question I had was, what did you guys notice from the MPOX breakout? Just saying from a gay male standpoint, I saw how the community handled it pretty quickly. But was there things that you guys learned from that?
I definitely think we're still learning things, because I mean, I will just so that everybody is where we're seeing an increase in MPOX nationwide. We've had about 4 cases in the last 2 weeks. We hadn't had a case since July. So we're definitely seeing an increase even here locally. One of the things that I think that was really, really hard, and I think this is going to be the case for anything that is new to us, is the information that we were receiving from the CDC was the same information that you guys were receiving from the CDC. We did not have any extra really information. So that was the first thing. The second thing is people wanted treatment and vaccine immediately, which I want to provide that to them. And there was the CDC started as the gatekeeper. I'm really hoping that the CDC has learned their lesson, because every time we got a case, I'd have to get on the phone with the CDC that night and say, hey, I have this person, la, 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 la. And then they'd say, oh, we'll ship it in 24 hours. And 36 hours later, it would show up. And then we got like a cache of like 10 vaccines, and we can only provide it to the context. So like the trickling in of the things that we needed to support our community was really I'd say the biggest issue. And that wasn't really an issue locally. It was really about the CDC being that gatekeeper. And I would have hoped they would have figured that out from COVID, but apparently they did not. So I'm hoping that this time that they've learned their lesson. And I think the third thing that has been a really, I'm not saying that this is still going on as an issue, is TPOXX. TPOXX is the primary treatment for MPOX, and the problem is that it's an off-label use, and so it hasn't been approved by the FDA, and so all of the orders have to. You can't just give a prescription to somebody, have them go to their pharmacy. There's hoops to jump through to get that. And I think there's currently a trial going on that anybody who's a new case is encouraged to be part of this trial, so that we can get this drug FDA approved, so that we can just have somebody go down to the pharmacy and get that treatment and have it be a lot faster. And there's hoops to go through to get that timely as well, because all that comes from the CDC as well. And then the last thing I think that was really, I think more on our side, is just keeping up with the education that goes out there, because that was the hardest part on our end, is making sure that we were messaging things properly, and it was getting to the right people, and also making sure that our providers were getting the information. We were sending out health alerts, but that doesn't mean people are reading them, and we would find gaps, and we have people who go around to our providers and do education on like the HIV testing algorithm, and syphilis, congenital syphilis with the bacillin shortage. We also had that person going around doing education about MPOX, but there are a lot of providers, and there's a lot of providers that are not used to that kind of treatment. Most of the people end up going to our SDI clinics, really. I think that they did. I think that the people who got vaccinated were the ones who got vaccinated, and we're finding that. And what I didn't say is those 4 cases that we've had in the last 2 weeks were not vaccinated. So we need to get back out there and remind everybody, hey, just because we haven't had any cases since July doesn't mean that you shouldn't get vaccinated.
I have wondering if you all have developed strategy. To any other services, and she wasn't on a register, she wouldn't have been identified. And I know that there are, having worked in the field, I know that there were a So I wonder if you all have even begun to strategize how to reach that group because they're so not connected.
Yes, we've thought a lot about that. So it is difficult when they're not connected, and that's why we're making a big effort to get people signed up in Warren Central Texas and get connected through these outreach events. But there's still going to be people out in the community that are completely disconnected. And at the very least, the most important thing for them to do is to at least call 311 to let the city know that, make them aware that they're at home without electricity. In public health, what we've been working on is a project with our community health workers where we're forming foot teams. And so using these registries that we have, STEER, the Austin Energy Registry, and the, oh goodness, yeah, those two, and layering them so we can then see where there are power outages and we can send those foot teams out to check on individuals at their homes. We actually did do that during the last winter storm and last February. We didn't have a lot of it planned out. So unfortunately, we only had one team of 2 community health workers doing it. It was kind of like a makeshift plan where we were like, hey, we have these 2 people. The weather was good enough to where they could drive out, but we knew that there were still people without electricity, and they were able to access individuals. For example, a woman, 87-year-old woman that had been without power for several days, that had run out of food and water. They were able to bring her food and water and connect her to us so she could we could make sure that we continued checking on her. So we've expanded on that program, and now we're planning on having at least 10 teams out in the field that we can quickly deploy to areas. But the most important piece is knowing that people are out there. And so if we don't have them on a registry, if they have not registered on STEER, then it is important for them to reach out and call 311 and for their neighbors to also advocate for them and know that they're there.
If there's that person, because a lot of individuals don't have other family members, so that but the neighbors might take care of them, so that they could then follow the role of what a family member would do and get them registered on one of those registries.
Yes, so from the communications office, I was actually just at a press conference this morning where we were communicating this, so the media is amplifying this message, but I know that the Office of Homeland Security and Emergency Management has been doing a lot of work with using different channels to advertise these various ways of these different registries. I don't have the information of exactly where they've reached outside of those preparedness fairs, but it is ongoing work that they've been doing. And if an emergency is happening, I know that there is going to be an increase in information that will be pushed out through the media outlets and through the different next door and the unofficial communication pathways. And that I have noticed has been an improvement from the past with our emergency management.
I just have a couple of comments. One, getting tested and some of the things I found that the drive-by testing, thank God you guys set that up. I had my to get a test when I was there visiting, and it was so much easier and nicer. And when you guys said being able to make appointments was not, you know. Also, on the other hand, I had the opportunity to work with you guys to do counseling for the phone with individuals who were positive, and it was a very rewarding experience. I mean, because none of us, I don't like people calling me anymore. I don't take calls that look like they're scams, and I had about a 70-some-odd% rate of people taking my calls or calling me back, which I'm not sure what the average was, but I think that's a pretty good number. How many dedicated individuals I had the opportunity to work with, and just the connection I made with clients on the phone that you never met face to face. And one of the things that for me that was really neat was I'd get this feeling about this person that they weren't telling me everything. And I would have this like almost a panic attack. And I would go ahead and push a little further. And some of those people, I said, you need to go to the hospital. That was the sort of thing that was happening. And I don't think a lot know to what extent, if you didn't receive one of those calls from one of us doing that work, and I'm thinking I was working with about 40 or 50 people. You might verify that. I don't remember what the number was, but
we had about 50. And then after vaccine, we thought we didn't need them anymore, and we
Yeah.
let some of them go. And about 2 weeks later, we're like, wait, come back. We still,
Yeah.
we still need you. So that was, we got to be about maybe 30 after that.
Yeah. So, but anyway, I want to thank you for all your work on that. And as someone who got to do that as well, it's a great job. Thanks.
We're just about out of time, but I did want to ask more question, basically for the folks over here, because these are our frontline providers who are going into the long-term care community. And we know from our past experience that we didn't handle that right during COVID. And we had a lot of people who were stuck in their nursing communities that were not getting served. So very quickly, what are some of the lessons we learned from that and things that we've put into place for making sure those types of things don't happen next time?
So, I mean, it's really a difficult group to keep up because there's a lot of shifting of contacts. There's just a lot of turnover at long-term care facilities, unfortunately. But I do know that my team is still in conversation with most of our long-term care facilities because they still have to report anytime they have a COVID case. And I mean, those connections, when we don't start hearing from somebody, we try to reach out and identify a new person. But it's one of those, it's a challenge because even before COVID, when I did flu outbreaks and norovirus outbreaks at long-term care facilities one year, and I'd get the same one and it would be a completely different person from the previous year. It's really hard to keep engaged with those. And so if you guys have some ideas, I would love to hear them, but it's just since we don't have a good way of communicating and making sure that the message gets to the right people, since we have such a shifting workforce. Yeah.
In all of the nursing homes and facilities that during COVID, a lot of them have started using a standardized email that doesn't turn over the name of every, because you're saying once a year, we think they change over 3 times a year. I mean, it's like if somebody's in 6 months, they're a veteran.
I was saying that the outbreak happened a year later and it was a brand new person.
Yeah. But a lot of the facilities have started having the intake coordinator or the wellness director or the head nurse have, just an email address that's nurse at blah, 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 so that it goes to whoever replaces.
That's really great because I think that had definitely been a challenge even pre-pandemic.
What about the licensing people? I mean, there's overall though.
I've used their website in the past, and it goes to a lot of them just go to a corporate office. It doesn't actually make it to the people who it needs to make it to, because we used to send out a letter every year about how to protect your facility's people from a norovirus outbreak and a flu outbreak. And I would call up after someone, did you receive that letter? Like, oh, I never saw that letter. So I mean, we use that as a list of a way to get a hold of people, but I'm not sure how successful it is.
Because I noticed with COVID that people didn't take it seriously until like CMS came out and said, we're not paying you if you don't vaccinate your people.
Mm-hmm.
And it seems like that might be a way to kind of make things clear, but I don't know.
I'll say that based off of the laws that were passed about the COVID vaccine, I don't think that that's going to happen.
Yeah, we are running out of time, but we did have one quick question that came from one of our folks who is online with us. Can you talk just a little bit about outreach and communication for these outlying areas of Travis County? Because we know that the majority of the older adults that we serve aren't living in Austin anymore. They're here on our fringes. And so because they are so vulnerable, what is some of the plans that we are putting in place to be able to address them?
Yes, so Austin Public Health serves both the city and the county. We work very closely with Health and Human Services to reach a lot of the areas in Travis County outside of the city. We are, I'm not sure if y'all have heard of resilience hubs, but doing a lot of work with advertising specific locations that are not just in the city, but also in the county that can serve as beacons, and people know that they can go to those whenever there is an emergency. I have not really kept up too much on the county side with Health and Human Services, so I'd like to get more information about that and get that to you. But there was one thing, I know that you were closing. I wanted to use this opportunity since there are a lot of providers here. I talked about the registries, but if a disaster does happen, I'm not sure if you all are familiar with multi-agency resource centers. It is something that is stood up as a recovery effort, and it's a location where different organizations can come in and provide services to those that were affected by the disaster. That's something that we will for sure open. We might open just one or several depending on the magnitude of the disaster. And it is important to have different providers come in and participate in those multi-agency resource centers to help provide resources, share information, and reach the populations in those areas. And so I have my cards here, and if we could exchange information, that way I can add you to a list. Whenever we are opening these recovery centers, we can make sure that we're actively communicating. There's other information that I think we could share as far as long-term care facilities, because we do also, it's a two-way street. We rely on them as well for when we're looking at beds. Instead of having to open a whole medical shelter, we might just need one bed, and hospitals don't have the capacity. And so making sure that we're maintaining that relationship with them as well for the emergency preparedness side. So anyway, I welcome you to continue the conversation with me. I've got my card up here. Thank you.
Thank you so much, Heather. Anna, thank you very, very much for being here and sharing all this information.